was calling. So right now, the only disclosure is this company called HiskiMed that I associate with them. They provide these fibro test or fibroscan machines. So if you need one, just talk to me and I can hook you up. So now we're going to talk about, we'll start with a case presentation. These are patients that we all see who come in with fatty liver. This is not the actual patient. Just to let you know, this is a generic internet picture. So this is a 64-year-old who had an ultrasound done somewhere else and was referred to us because of moderate to severe fatty liver. And BMI was 32. Labs had been done to rule out other causes of steatotic liver disease, such as hepatitis B, hepatitis C. She had recently or diagnosed to have diabetes a few years ago, diabetes type 2, and she's on oral medications and atorvastatin. Her labs included elevation of ALT, gamma GT, also slightly elevated, platelets somewhat low. How do you proceed to see this patient? So I want us to have this talk about fatty liver, to think about this patient as we proceed, because these are people who come before us every day, and we need to ask ourselves, what are we going to do with them? Especially you people who see diabetic patients. This is very common. What would you do next? Any takers? Huh? Yes. I can. Yeah. Somebody has said FIB4, but what we did, we took them straight to this machine. Because if you have a machine, you should use it, right? Anyway, but we'll talk about the guidelines. So this was what we did. Fibroscan was done, and there was moderate F2 fibrosis and severe steatosis. So then what would you do from here? So that's what we'll be trying to address in our talk in the next few minutes, what to do for this patient. So as you all know, there is this new terminology is MASLD instead of fatty liver. We're trying to remove the stigma. We don't want to tell a patient that, look, madam, your liver is very fat. It's bad. We don't want to use those terms. So we want to use better terms like MASLD. You can tell the patient, your liver has MASLD. So anyway, it's defined by a patient who has steatosis in the liver of 5% or greater, and one or more risk factors such as obesity, diabetes, dyslipidemia, or hypertension. So any of those four plus fat in the liver is called MASLD. As you'll see, the other categorizations, people who drink a lot of alcohol, we cannot put them in this category. So the definition also says they should not drink a lot of alcohol. And the definition is clear. Per day, 20 grams per day of alcohol in women and 30 grams per day in men. I don't know why they are more generous towards men, but to give you an idea, 20 grams is just, usually a big glass of wine is probably about 18 grams. So for women, just 1 glass, for men, 1.5. Beyond that, that's our choma. So I will not name names, but let's just say this is where, this is a guideline we should look at, okay? Now, this is the new classification. It's no longer new, but it was published in 2023. So MASLD, this is where we are, metabolic dysfunction associated steatotic liver disease. And then when you start drinking a bit of alcohol, then there's a category called MASLD, where you have a bit of MASLD and a bit of alcohol. As long as you're between 20 and 30, at not more than 50 to 60 grams per day, then you're in this category. Once you pass that, we no longer call it MASLD, it's just alcoholic liver disease. When you pass that amount of, we said 1 glass or 1.5 glasses of wine a day. Then, what about other conditions that can cause steatotic liver disease? You can have drug-induced liver injury, monogenic diseases, such as what we talk about, Wilson's disease. Then you have others like hepatitis B, hepatitis C. All those can cause steatotic liver disease. And then there's a category that is cryptogenic steatotic liver disease, and that still exists because it's not clear what is causing it. Then, when you talk about you're trying to make the diagnosis. So our patient came in with fat in the liver from the ultrasound, and then Is there any cardiometabolic criteria? Yes, there was diabetes. So you come down this pathway. If it's no, then now you're talking about other causes, and you can end up in any of those categories that we discussed. So in the past, this was thought to be a foreign problem in the West, and it is a big problem. MASLD is the #2 cause of liver transplantations in America. Okay? And in Europe, it is the fastest growing cause of liver transplant. So it's not a benign thing. Often, when patients go and they get an ultrasound and there's fat in the liver, they're told, don't worry, everybody has this, it's harmless, just a little fat. That is wrong. For it to be the #2 leading cause of liver transplantation in the US, it means it's a serious thing. Even here, it's probably responsible for several patients who have end-stage liver disease. So it can be chronic, it can be life-threatening, can lead to liver cirrhosis, liver cancer, and that is why we are seeing it is also our problem. Studies done locally have shown, and we've heard it even from the previous talks this morning, obesity is on the rise in Kenya. And in Kenyan men, it's about 29% from this study done in Kenya, and 40% in women. So women tend to have higher levels of obesity than men, and part of it also, socially in our country, it is still considered a very good thing for a woman to have a bit of excess fat in certain areas. So, so that I think we need, and maybe it's not a bad thing, because as we heard this morning from the talk by one of our speakers, the waist-hip ratio is important. So I guess, thank you. Yeah, so even as we're looking at that, we still consider the waist-hip ratio, but all in all, this is a rising problem. Overall prevalence of metabolic syndrome was 25% from a study done at Aga Khan. And what is the pathophysiology of MASLD? So I'll not dwell on that very much, but the main #1 issue is insulin resistance. So this is the main issue. It leads to lipolysis, triglyceride synthesis, and increased liver uptake of free fatty acids, and triglycerides accumulate. So incretins are also known to contribute to this, and that is why they are targeted now in a lot of the medications that we've heard about, GLP-1 antagonists and GIP. Then gut microbiota. So it's been found that higher Bacteroides and Prevotella counts were associated in MASH, that is MASH, that is where you have steatohepatitis. So there is that association, but at this point it's still not a target in therapy, but it might be a future target. Oxidative stress, traditionally vitamin E has been used for MASLD, and this was the target. Genetics also play a role, leptin and adiponectin, which probably can be targeted as we move forward. So, in patients with diabetes, and these are the patients we discussed a lot, the rate of MASLD is extremely high as 67%. Previously it was 55%, but now it's as high as 67%. So literally, almost any diabetic patient you see probably has MASLD, should be screened. The guidelines recommend that, and we'll talk about how that can be done. And the global prevalence in type 2 was 41%. And so these are numbers which are really, really increasing, and there's a 51% increase from the world diabetes predictions. And how do we make the diagnosis in our patient who came in? Usually they don't have symptoms. They probably went in just for a routine checkup for maybe gallstones or some unrelated thing, and then they saw that there was some increased echogenicity in the liver, as what you can see here. Normally, the liver is supposed to be the same shade as the kidney. But when you see the liver is very bright and white like this, and the kidney looks darker, that is an indication that there is some steatosis going on. And occasionally, if there is inflammation or MASH, you might find the LFTs are a little high, and you need to rule out other causes in making this diagnosis. Make sure there's no hepatitis B, C, autoimmune hepatitis is something we see quite a bit of nowadays, and other causes such as alcohol, to be able to come clearly with the diagnosis. Then the other thing that is recommended is vibration-controlled elastography, such as FibroScan and FibroTest. These, they use control attenuation parameter, or CAP, or UAP mode, to quantify the exact amount of steatosis that you're talking about. And this is something which, of course, is not available everywhere, but where it's available, it can be used. Where it's not, we talk about things like FIB4, which we'll talk about. So today, we'll focus a lot on these guidelines that came out last year. Joint guidelines from ESL, ESD, and European. So joint European guidelines from the societies dealing with liver, diabetes, and obesity. And so those are the things that we'll talk about. And there's statements which were released in these guidelines, which I would like us to focus on to guide our practice. So number one, the finding of steatosis in a patient like ours who came in with just a test that was done that showed fatty liver, we should look for potential etiology in addition to just, we don't just call it MASLD, but look for what else could be causing. And often you find patients are diagnosed to have hepatitis C, they can be treated and actually get a resolution of this disease by making these tests. So the other statement is that patients who have diabetes, obesity with one or more metabolic risk factor and abnormal LFTs, we should also screen them for MASLD. We should look for MASLD in these patients. So the key, I think I would say, is because these are diabetes conference, that these diabetic patients how do we go about this? The first multi-step approach is recommended. First, you need a blood-based score such as a FIB4, which is very easy and it has been well validated. It can help to try and find out, or does this patient have a risk of fibrosis? Because the minute you go into fibrosis, that tells you must act, you must do something. And then thereafter, I'll show you the next slide, the VCTE can still be used if fibrosis is suspected or in high-risk groups. And so this is how we do it. So in these patients whom we are screening, we do the FIB4. If the number is less than 1.3, so you know that they are at low risk of getting or having fibrosis. So you reassess with the FIB4 every 1 to 3 years. So remember, this is literally any diabetic patient that you see. And then if they fall in between this category of 1.3 to 2.67, then you have to now do intensive management, or you take them straight to VCTE, the fibro test, and you're able to document the exact number that you're dealing with. And if the number is less than 8, then you intensify. If it's more than 8, then now you have to send them to us. So Dr. Ajua and I will look and do whatever other tests are required. So the FIB4 is quite easy to do. You just need the age, AST, ALT, and the platelet count. And you see nowadays, when we were students, we used to really memorize all the formulae. But now, you just have an app on your phone. You just plug in these numbers, you have a number. So I'm not even going to try and figure out what that formula is. So how do we do imaging? So now you've done the FIB4, or maybe, and now in that middle category, you want to do further assessment. Abdominal ultrasound is used a lot. Sometimes it's very user dependent. It doesn't always correlate, but it can help you to clarify what's going on. There's a special MRI called MRI PDFF, not available in Kenya as far as I know, but it can also help to quantify the amount of fat in the liver by looking at the shade of blue. The carb measurement using a fibroscan, this is available now in probably 2 or 3 places, and you're able to get a definite number like 335. It's very clear that when the patient does the lifestyle, come back in 6 months, let's see what your number is. Now you've lost a few kilos, maybe you're 300. You keep coming down. It's a good motivation